Hi, how's it going? Thanks for studying with me today. We're going to be talking about the concept of sensory perception from your Giddens chapter 27, as well as Davis chapter 30. These are the objectives you're going to want to accomplish as you listen to this lecture today. You're going to complete your concept study guide on sensory perception, define and describe the concept, notice the risk factors for impaired sensory perception, recognize when an individual has impaired sensory perception, and provide appropriate interventions, whether nursing interventions or collaborative interventions, to optimize a patient's sensory perception. Go ahead and write those down and be prepared to answer them as we go through this. So let's go ahead and define and describe the concept of sensory perception. Sensory perception refers to those 5 senses that we learn in kindergarten. Do you remember the song, head, shoulders, knees and toes, eyes and ears and a mouth and nose, right? It's the sense of smell, touch, taste, sound, and sight. And so the way we perceive our environment through all these various inputs, through various physiological processes in the body, and how we transfer that stimulus and translate that into meaningful information that we can make sense of. So sensation and perception occur throughout our body, and the level of functionality of our sensory perception ranges from optimal, perfect, beautiful functioning to impairment, where we have a difficulty with one of those senses. So sensory alterations. You may hear the term sensory deprivation. You might have heard of these sensory deprivation tanks that are supposed to be a phenomenal experience to experience weightlessness and a lack of all sorts of outside sensory perception to really create a sense of calm. And so we may think of sensory deprivation as a good thing. It sometimes has a positive connotation. But unfortunately, for patients like ICU patients, the lack of sensory input can have a really terrible effect on their quality of life. Sensory overload is on the other end of that spectrum, just too much information. And a lot of times patients will really start having a hard time with all the alarms and bells that go on at night. If your child has ever been on a road trip with you and you've got different people having different music playing, or the video game sounds, which are just so annoying, I get very overloaded on that. And when we're on road trips, once in a while, I'll just say, listen guys, we just need peace and quiet for like 30 minutes, just no more radio, no more talking, can we just have some quiet? Because my brain goes on sensory overload, too much stimulus that we can't process it all. And then there's sensory deficits. Sensory deficits are changes, alterations, and decreased ability to have sensory perception on one or more of your 5 senses. Your Davis text really describes this well. So go ahead and take a look at that, page 780 to 82. So as we said, the sensory system isn't going to include all 5 of your senses: vision, hearing, taste, smell, and touch. For the focus of this class, we're going to be focusing most specifically on vision and hearing deficits for this class. So visual impairment is the first example of this. Impairments range from minor distortion to just needing some contacts or some glasses, or maybe glasses just even when you read or drive, to complete blindness and complete disability. Injury and developmental delays may happen based on the level of severity of a visual impact. If someone can't see their surroundings, it can cause, risk for getting injured. And there are psychosocial consequences involved with visual impairment, including learning difficulties, because you're lacking one of the most key senses for learning new information, depression, anxiety, a loss of self-worth, and difficulties with interpersonal relationships. Hearing impairment is the second variation and context of this concept, and impairments can range from minor distortions to complete hearing loss. And I watched my husband's grandfather go through this progression from just having to speak up a little louder to him really not being able to hear conversation at dinner, and ultimately acknowledging his own deficit and getting help in the form of, a hearing aid, and it made a big difference for him. But I watched him go from this scope of minor distortions to complete hearing loss. So injury, again, if we're lacking our sense, you might have seen, if you've ever seen when you're driving down the street, you'll see deaf child at play. And so parents of deaf children may put signage out because their child lacks one of those main senses to keep them safe and avoid injury. Patients can have communication difficulties, both sending messages and receiving them. And again, developmental delays can develop. There are psychosocial consequences for hearing impairments as well, including problems with relationships, learning, work, feeling isolated, and a general frustration at this ongoing challenge with communicating in everyday life. Again, for the purpose of this class, we're going to focus most on sight and sound, but we will cover a couple of these other variations for today. Impaired taste and smell. Impairments can result in anorexia, just not feeling like you want to eat, weight loss and malnutrition. There's something satisfying and delicious about food, and if that satisfying deliciousness is taken away, it's not as much of a motivation to eat. Food poisoning can occur from the indigestion of spoiled food. When we open the fridge and we open up a gallon of milk, and you can tell it is off because your nose tells you that. But if you're lacking this sense of taste and smell, you may not know something's off. Safety can occur there's a risk of safety issues from environmental dangers, not being able to smell if there is a gas leak, for example. And activities of daily living and occupational skills can be reduced as we really do depend on all of our senses to get our work done. I had a good friend that I worked with a few years ago, and when he was in his early 20s, he was actually mugged at gunpoint and beat up and had to have multiple facial surgeries to repair his face, and he lost his sense of smell from this assault. And he told me that bananas did not sound good anymore because bananas didn't really have much taste. And most of the taste that we got from them was really from the scent. And so he just had no interest in eating bananas anymore. And quite frankly, he ate because he had to, not because it was as enjoyable, because a lot of our taste and smell are intertwined in terms of what we take in as food. So he just definitely didn't have to worry about going on a diet after that, that's for sure. So let's talk about the risk factors for impaired sensory perception. Who is at risk for having challenges with their hearing or their vision? I don't think it would come as a big surprise that most commonly the elderly population is at risk for lack of vision and hearing. And you'll see that, many elderly patients are wearing glasses, and many of them have hearing aids, and you don't see as many hearing aids in the younger population. So this should come as no surprise. But there's no real significant population risk factors, nothing we can pin to race or ethnicity, gender, or socioeconomic status. Those just are not involved in the risk factors. But in general, it's accepted that as we age, we lose some of these abilities with our sensory perception. And it may just be a cause of aging, or it may be a side effect from some of the medications or treatments that these patients are on for some of their other chronic conditions, like heart medicines. So how do we recognize when an individual has impaired sensory perception? Well, we can examine the vision through a number of techniques. First would be the examination or inspection of the external eye. And this is on page 265 of your Giddens if you want to read along with me, but we're looking at all of the external eye structures, including the eyebrows, eyelashes, and eyelids. And we're looking for things like symmetry, size, and extension. The nurse should palpate both the eyelid and the eye and inspect the conjunctiva. The conjunctiva is that thin membrane that covers the inner eyelid, and then the sclera, which is the whites of our eyes. We look for things like redness or irritation, discharge or flakiness. We can perform a visual acuity. We've all had this done at the eye doctor, right? Where they hold up the sign with the different letters and we have to cover one eye and read the sign, cover the other eye, read the sign, have both eyes together, read the sign, and tell us how good that we can see from a distance. It's called a visual acuity test. And any one time that a patient comes in with eye injury or eye issues, we typically want to make sure we do a visual acuity to see if the patient's vision is impacted by whatever is going on. We look for things like eye movement and can they follow an object? Do they have something called nystagmus, where their eye just wobbles back and forth and back and forth? We can perform an ophthalmic examination, where an eye doctor may be visualizing more of the inner aspects of the eye using different tools and equipment. And then we can assess pupillary response. So our pupils are going to be measured in millimeters, and we can look and see, a lot of times you can get a little chart with different diameters of eyeballs or pupils, and you can look and see how large is someone's pupil in millimeters, for example, 4 millimeters. And we can shine a light and see if there's a brisk reaction to that shining of the light. So our pupils should constrict at the sight of bright light and then open back up and when we have less light. And so we want to look for that pupillary response when we're assessing vision. Now for hearing, we can do hearing tests, and all newborns get a hearing test before they leave the hospital to make sure there's nothing that we can recognize, from birth. And certainly you can get a hearing test at your doctor's office as well. We can also inspect both the external ear and the inner ear using an otoscope. And sometimes hearing perception or hearing deficits are just caused by a whole lot of wax buildup. That happens more often than you'd know. And ER nurses get real good at being able to clean wax out of a patient's ear and irrigate that and soften it. And yeah, it's just part of life sometimes. But thankfully, it sometimes is as easy as just clearing out something that's physically obstructing the patient from being able to hear well. So remember, taste and smell are interconnected. If you look at maps of or charts of the way our diagram of our anatomy, the nasopharyngeal area is all connected. And so we want to look in the oral, we want to inspect the oral cavity, look at the tongue, inspect the nose, looking for patency of the nasal airway. That means, is there anything obstructing it, or is that airway clear? We can do taste testing, that sounds fun, and we can also test for smell. Now remember, we're not getting too deep into the taste and smell aspect of sensory perception, so go ahead and speed read through this part just to get the big picture for this class. Now, in order to assess the sense of touch, we often touch and balance, or tactile, which is touch, and balance are often hand in hand. So providers can do this Romberg test, where a patient has to stand up straight and close their eyes for a full minute. And as long as they don't fall, then they've passed the test. Sometimes police officers do this when they are investigating someone for a possible driving under the influence. We can do tests for hot and cold, and whether or not a patient can perceive the difference in temperature, something sharp or something dull. And can patients localize a sensation? You'll see this in a neuro exam. The doctor will say, okay, close your eyes, patient, and they'll touch their hand. And they'll say, which hand am I touching? Do you feel me feeling that? Do you feel that? Do you feel that? And that's a way they can localize sensation and see if those nerves are firing and if the brain's picking up on that. And finally, the monofilament testing, where you take a single little thread and you brush that on the patient, typically on the feet, to test for sensory perception, ability to have tactile sensation. Again, just read through this part, get the main ideas, and move on. So some of the visual tests that you're going to see as diagnostic tests, you would get as part of a typical or comprehensive eye exam. Something like visual field testing, where someone looks into a box and they'll have a dot display on one part, and they have to raise the hand on where they're seeing that on the screen. That's testing your visual field. How far do you see? Or you might see something like non-contact tonometry. Oh, I hate this one. This is the one where you sit and they blow that puff of air in your eyes, but it's sensing for what the pressure is within your eye, because there is a normal level of pressure, and anything higher than that can really indicate a problem. And if someone is really having true hearing problems, impairment, vision, or hearing loss, they'd be referred to an audiologist who has a number of tools in their toolbox to perform additional hearing assessments to really gauge what type of hearing loss this patient is experiencing. So what kind of interventions can we do as nurses or collaborate with our healthcare providers to optimize sensory perception for our patients? Well, let's talk firstly about primary prevention. Remember, primary prevention means activities that we do to keep a problem from ever happening in the first place. And so we want to encourage the community to use things like safety devices to keep our eyes safe. Or our ears safe. So if you're going to a concert, put earplugs in, because over time, really loud noises can damage our hearing. If you're working out in the garden with the lawnmower or the weed whacker, or you're doing some construction, make sure you're wearing eye protection so that no debris gets in your eyes. We put erythromycin drops in the newborn's eyes to prevent infection, anything that they could have gotten from the mom during the birthing process. And we want to have proactive management of chronic conditions for things such as heart disease and diabetes, recognizing that those conditions themselves can cause changes in sensory perceptions, or sometimes the medications that are required can cause changes in sensory perception. So we want to make sure we're preventing some of those things from needing to be happening in the first place. When I was in my early 20s, I was really undiagnosed hypothyroid, but they thought I had some sort of arthritis, like rheumatoid arthritis. They just weren't sure. And I went through a period where I was taking some pretty significant drugs. They were actually called anti-malarial drugs, but they worked for things like rheumatoid arthritis. But one of the side effects to this drug was that it could cause changes and problems with vision. And so I had to go to an ophthalmologist, an eye doctor, every 3 months for very intensive eye exams to make sure that from the side effect from the medication that I wasn't getting vision loss, which would have made a whole nother problem. Thankfully, I didn't have to stay on those meds very long once they figured out my thyroid was just dead and I needed a little pill for that every day. So in terms of interventions for vision, there's options like surgery, things like laser surgery for visual acuity correction. Removing of cataracts is another common surgery you're going to see for vision. And then there's pharmacotherapy, some drugs that we can use to help with a variety of vision problems, things that either decrease inflammation, decrease pressures in the eye, increase tearing of the eye, or dry your eyes out more. It just depends on what the patient's specific vision problem is. And of course, there's adaptive methods depending on the severity of the vision loss. So things like eyeglasses or contact lenses, or even teaching and providing resources in Braille, or even guide dogs to help promote safety and independence for patients with severe vision loss. Now for hearing, there's a couple surgery options that are most common as well. We've seen people with cochlear implants that literally are able to provide externally something that the patient just does not have internally, and they're able to hear with this external implant. Or meningotomy, if you've heard of kids having a lot of ear infections and then they have to have tubes put in their ear, and it's allowing fluid to drain freely from the ear and not have frequent ear infections. And the most common types of pharmacotherapy for hearing include things like antimicrobials for bacterial ear infections, antibiotics, steroids to reduce pain and inflammation, and analgesics, even things like Tylenol and ibuprofen to help with pain when there are hearing problems that are acute. And certainly with those who have hearing perception issues, you can use many adaptive methods such as hearing aids, assistive listening devices, or even sign language. Keep in mind, these hearing aids are extremely expensive and insurance will only cover them so often. So many times our patients won't come into the hospital with their hearing aids because they don't want to lose them and they're so small. And we can, quite frankly, be a little careless when we're changing beds and not paying attention for little items. And those can get thrown out. And so we need to be very mindful if our patients have hearing assistive devices, that we are careful with those when they're in our care so that we don't throw those away. For smell and taste, sometimes you can have surgery to remove nasal polyps or to increase the diameter of the sinus cavities so that they can have better drainage of fluids so that they don't get recurrent sinus infections. Oftentimes, pharmacotherapy includes steroid sprays like Flonase, antihistamines like Benadryl, and you can have adaptive methods as well. Specifically, adapting your environment when you're at risk for causing damage to your smell and taste perception. So using things like masks or being careful of what harsh chemicals are used in your workplace. And those with challenges with tactile sensation will often use adaptive methods as well. Things like lowering the temperature on their hot water heater so they don't scald themselves in the bathtub because they just can't feel how hot it is. Or people with poor sensory perception in their feet, making sure they're wearing proper footwear to keep them safe because their brain wouldn't necessarily trigger them to tell them when they're having pain from an injury. In terms of interrelated concepts, the most highly interrelated would be intracranial regulation. So all of these senses are perceived and translated, and meaning is found of those senses from your brain. And so any changes or dysregulation in the brain is going to have a huge impact on sensory perception. Pain is also related. We don't like to think about pain as a good thing, but pain tells us things when we need to know them. And so if you're not able to feel pain, you might not be able to keep yourself safe. Mobility. If someone has decreased sensation, like paresthesias after a stroke, they may have a hard time getting around and it can impact their mobility. Nutrition can be impacted because you're unable to really desire to eat if it's taste and smell. And this can cause nutritional deficiencies. Oftentimes, we're going to see this with our chemotherapy patients, as often the chemotherapy drugs themselves cause changes in patients' sense of taste and smell. Development can be a problem, especially for children who have hearing or vision impairments from an early age or from infancy. It can affect their ability to learn and grow at what we would call a normal level. And then finally, functional ability. So if someone's lacking something in the ability to perceive their environment, they may not be able to fully care for themselves independently and can impact their sense of function. So here's a list of featured exemplars from your Giddens text. Presbycusis is the term for age-related hearing loss. This is our typical hearing loss we're going to see in our elderly population where there's no specific cause other than the fact that the patient is aging. Otitis media meaning middle, is this inner ear infection that we most commonly see in children. It's defined as, a pain and sometimes a fever, and can oftentimes be resolved through things like antibiotics. Nasal polyps are growths within the sinus cavity that often happens through patients who have chronic inflammation in the nose and nasal passages. And this can impact their ability to smell, often leading to partial hyposomia, hypo meaning low, or complete loss of smell, anosmia. Meniere's disease causes ringing in the ear, which can be very troublesome and bothersome to patients, and often also times causes dizziness. Raynaud syndrome is caused by vasospasm of distal arteries, and arterioles that limits blood supply to the distal extremities. Specifically, you'll see this in the winter, especially in Chicago, with patients or people out in public where their hands turn blue or almost pale just when they're out in the cold. Now you can see chemotherapy-induced alteration in taste, as we discussed earlier. And finally, diabetic retinopathy. It's the leading cause of blindness among adults in America. And the uncontrolled diabetes actually causes changes to the blood vessels of the retina. And by losing your retina, then you can, over time, have blindness. And so this is why good control of our diabetics matters, because it's more than just controlling blood sugar. It affects so many different body systems for our patients. Go ahead and just read through these featured exemplars that we just discussed on page 268 and 269. Thanks for studying along with me on this topic. I'm always grateful to be able to share this time with you. Have a great day, and we'll see you soon.